Welcome to the LowCarbUSA Podcast, where we seek to inspire you to help us build this community. I'm Doug Reynolds.
And this is Pam Devine.
Hey, so I've got Naomi, Parella, and Jim Howard here with me from BioSense. And we kind of decided to talk about this coming out of the MHS summit that Jim was saying that there was a lot of talk there about this concept of ketosis dosing. And we wanted to talk about that here, but I think, Naomi, maybe let's start out by kind of defining what that even means, because I didn't even really know exactly what they meant when they talk about ketosis dosing.
Yeah, so ketosis dosing. So basically, when we have individuals, we encourage them to eat in a way that puts them into nutritional ketosis, whether it's from fasting, low carb, ketogenic diets, meal replacements, whatever it is. We want to make sure that people are actually doing that well and effectively so that they get the outcomes they want, right? Whether it's reversing diabetes or decreasing inflammation or improving cognitive decline. So those specific goals that people have, right? We want to know that we're actually doing the right thing and enough of it. So ketone dosing or ketosis dosing is basically saying that there's a certain amount of ketones your body needs to be producing over a 24-hour period, and that would be the dose. So we know ketones change throughout the day, even if you're completely adherent, and it's kind of helpful to know how you're doing. And right now, we can measure that and sort of graph it out so that you can see an area under the curve of, and that's the ketosis dosing or the ketone dose.
Okay. So it's a function of the length and depth of actually ketone bodies in production. So we measure that through breath acetone.
Right. Okay. So and we'll get to that in a minute. But one of the questions that comes up for me here when we talk about that is that I know for a fact that people are different, right? So very different in terms of the amount of ketones that they produce. I mean, Pam and I eat exactly the same way, and I'll be measuring 3.5 and she'll be struggling to get over 0.5. And that's very frustrating. And yet, I feel like in fact, I know that she's in ketosis. And because a lot of the time we've been eating pretty much a carnivore diet recently, especially. So when you talk about a particular dose, that's got to be very individual as well, right? So that this area under the curve, you can't just say your area under the curve isn't right. I mean, because one person could be very different to somebody else. How do you deal with that when you actually trying to look at this area under the curve, for example?
I can take a step with that. So I think that in the clinical setting, in the various therapeutic areas that we work in and all of the trials, it's absolutely individual, and it may mean you need to fast longer, or that your carb intake may need to be different than the person next to you, or you need to check your cortisol levels. All those different functions that impact your ketone production and ability to get into that dosing segment. I think that so it is different for everybody. The key thing is, though, in these therapeutic areas, it's Wild West. So it's we've thus far, for the most part, have said we need to get you into ketosis for this specific chronic disease to reverse it or prevent it in some cases. That's a very unstructured environment, but no different than, hey, you should just take this medication. Well, how much and for how long and how, and what time? There needs to be some type of structure there. And I think what we're seeing more and more of, and the keynote with John Rowe, for example, from UCSD, he was really clear at the end of the keynote. It was like, we need to stop doing this in an unstructured way and really start to monitor this digital medication, this nutritional medication that we're on, or that we're putting people into, and identify what is the appropriate depth and length. And you've got, there's some good examples of people already doing that right now in a clinical setting, but it's putting structure around that, really around this depth and length.
Okay. So,
I had one other comment on that, Doug.
Okay,
so with regards to specifically the differences between, for example, you and your wife, right? Part of that is you may have higher ketones in the morning because you check once in the morning, and she's checking maybe once in the morning as well. If she checked later in the day, she might actually have a different pattern than yours, right? Because individuals have different hormone cycles and circadian rhythms. And so it might be that if she was able to check more frequently, she could figure out which times are best for her with regards to ketones, and that's where the area under the curve matters, right?
Okay. Yeah. I mean, she's done a lot of testing, and maybe it does get a bit higher at different times in the day, but it's a bit higher. It's not like up to 3.5 like me, you know what I mean? But she freaks you out, like she hates it. But
yeah, it's so disappointing.
yeah. But I mean, that's the whole thing, is we try to encourage people not to be chasing numbers, right? Because everybody's different. So I think we need to, when we talk down the road, when you talk about dosing, I think individuality's got to feature into that conversation as well. Because you know what 2.5 for one person is not the same as 2.5 for another person. But you know, that really brings us back down to your device, which is a breath analyzer, ketone analyzer. And you know, how does this change things in terms of all of this measuring and stuff? Maybe you can help us understand that.
Yeah, so the BioSense device is it's the first and only clinical device that's designed to really track this trending area under the curve as it changes. So I would say that the most important thing to understand is that there was a 2019 trial that showed that regardless of how you measure your ketone levels, a single measurement per day was 50% off of a time-weighted average, which is really your area under the curve. So we you know, there's determination clinically that we're doing it wrong if whatever you're doing, if you're doing it once a day, it moves too much. So it's not like glucose, but it certainly does move like glucose to some degree. So there's a magical number of somewhere in the 3 to 5 or 6 measurements per day to really get that resolution of, hey, here's my metabolic journey at a personal level. And you're right, the personalized approach is critical. So with that, BioSense was developed by Readout Health, that's our company, and is really targeting for type 2 diabetes reversal, obesity reversal, and little did we know that there'd be so many other therapeutic areas. So it measures just your end of breath sample, and that's the patent and really makes this able to replace blood measurement, unlike the previous devices out. And it's just your alveolar sample, the last 2 cc's of your breath. And that's the patent, and that it just pulls in the high acetone or high ketone concentrated air, puts that into a closed vessel and measures it. And then you blow into it 3 to 5 times a day, and it gives you your area under the curve.
Okay. Yeah, I mean, I even had, I think they were Ketonics was their name or something, but I've had, from the very first conference I did back in 2016, I've had, you know, vendors there with a breath analyzer and a few others since then. And it's always been kind of disappointing because they just, you know, the idea that you don't have to prick your finger is cool, but the accuracy and the reliability of those readings was really brought into question. And you're talking about being, you know, more accurate and whatever. How is it that what have you found, or are you allowed to tell me what you found that's been able to make this more accurate?
Right. So first of all, it's the only one that's had a clinical trial. The clinical trial has led to the number of other clinical trials globally and to pharma partnerships. It all comes down to one thing, that is measuring the right part of your lung sample. So your lung is full of ambient air, which is the air around you. If a breath device measures the ambient air, it can't be accurate. So they're all fundamentally flawed. The difference here is that we only measure just the last 2 cc's where acetone, where ketones are highly, highly concentrated. Mm-hmm. And that allows us to make a direct correlation to BHB. I mean, keep in mind, BHB is a storage ketone. It's not it's acetoacetate that's metabolized by the mitochondria. So it's not a direct reflection of BHB because they're different ketones, but it is spontaneously, acetoacetate spontaneously combusts into acetone and is excreted out your body through breath. So if you do it right, and we do it right, you're able to get a very, very accurate measurement, and that's it. So that's the difference.
So when you come to this concept, I know like when I've worn a CGM, for instance, and I've had to check it against my blood levels and found that there's been discrepancies. There's calibration that needs to, you have to put these blood measurements in, the direct blood measurements in, so that it can calibrate itself. And even then you see a drift, and you see differences with individuals as well. Are you saying that across the board, every one that you get is accurate, and if you had to do a finger prick, you would find a similar correlation? I'm sorry, you know, I'm putting you through the ringer here, but
no, that's great.
Most people are skeptical about this if they've been in this space for a while. So I'm kind of asking questions for them.
Yeah, absolutely. So couple of key things. So the accuracy to acetone to a tank is 99.8%. So you compare it against acetone, the gas, that's the gas that's being measured. So it's 99.8% accurate when it leaves St. Louis. We're in St. Louis next to Washington University, where we have 3 trials ongoing. And the difference between that and a blood measurement, keep in mind, those are different ketones though. So the average, I would say the average person, it's about 10 to 1 BHB to breath acetone, which are called ACEs. You know, we convert parts per million into ACEs. So not everyone is 10 to 1 though. That doesn't mean anything's inaccurate or that there's a drift in the sensor. It's just that we all store different amounts. So Peter Attia and myself and Dom D'Agostino, we probably store less and less BHB over time. And probably you too, Doug. You know, so you may have a different ratio. But it's, again, your BHB is a storage, it's a storage thing. And you can't really compare to capillary so directly, because capillary measurements are about 20% off of a venous measurement. That's the gold standard, is the venous measurement. So capillary is a good measure, good proxy, but it's not the gold standard. So there's always going to be a little bit of a difference. The key is don't spend your life comparing apples to oranges. It's what is going up and what is going down and what is the dose of ketosis. But the key thing you asked is like, hey, how do you know about the sensor and the drift and things like that? The sensor will, over time, it will start to degrade. It should last, up to 2 years, unless it's being stored in a way that it's, around alcohol, hand sanitizer, things like that. And those are issues you don't have with a blood measurement, but you do with a breath measurement. You can't drink alcohol and then take a breath measurement and things like that. So the key thing is to follow the protocol of when to take a measurement. When you wake up, before a meal, before lunch, before dinner, and then at nighttime. And you will have a really good area under the curve with that. Really, really good area under the curve. And I don't think people are going to prick their finger 4 or 5 times a day.
Well, sorry, I was just going to say, when I was doing this comparison with the CGM, I was pricking my finger many, many times a day. But it's not fun. And it was for a month, so I could deal with it. But most people wouldn't have even done it for a month. It's just it's not fun. So yes, sorry, Naomi.
Oh yeah. So I was going to say, the question you ask is very valid, because that's what my clinics have been searching for years, right? Because we didn't like most of the monitors were inaccurate, and so we couldn't really base clinical judgment on the numbers we were seeing. So I was really impressed when at Rush University, right? So I was really impressed when I met one of the inventors, Tim Ratto, who explained to me why this sensor has a patent. What is very special about it? And he was basically answering my question about what about accuracy and reproducibility, right? And there's 3 challenges that the breath analyzers have that they've figured out. And one is that sampling, to make sure you're actually checking the air that's interacting with your blood, right? Because then that's not the air out here, but the air that's closest to your blood and that interacted with your blood. Second is sensitivity. And that means making sure you're actually measuring well what you're trying to measure, right? And that you're not missing things or grabbing the wrong particles. And that's also with differentiation, being able to tell which ketones you're measuring and not just measuring a bunch of different things and getting an inaccurate number. So they've mastered all three of those. And that's what the patent is all about, is this breath sampling to make sure we're not checking the air that it's still sitting in your airways because it's not interacting with your blood, right? We want to check actually what's happening in your body. So that's the key, is those three things can reassure you that you have better accuracy and reproducible results.
Okay, but you're still going to have different people having different curves, right?
Exactly,
So
and you would expect that.
So right,
Yeah.
exactly. How do you correlate that? So if you're in a clinical situation and you've got people with completely different curves, but they are equally in ketosis, and whatever the therapeutic reason is for them trying to do this is it's happening for them. But how do you know even what? How do you know? Different people, you've got different curves. How do you know that they're just not doing it right, or whether they are not using the sensor right, or whether they're not in ketosis, or what? How do you actually even go about defining that or deciding on that?
I think the goal is to simplify, right? And so, for example, with the breath acetone measurement, that's a really nice measure of the actual fat oxidation happening in the body, versus BHB from the blood, testing is going to change at a different rate than the acetone based on whether you're actually using the beta hydroxybutyrate or not, right, as a fuel source, right? So it could be that somebody is really adapted, and so they're going to have slightly different numbers, even though their body is burning a lot of fat, right? So then you'd want to check the breath acetone to see, am I actually burning fat, right? And so that can be very, very useful. And so, for example, if somebody comes to my clinic and they say, I want to lose weight for whatever reason it is, I can tell them, if you're using the BioSense device and your ACE number is 5 or above, we know you are burning more fat than you are replacing, right? That's pretty simple. So easy, right? And that measures roughly, it correlates with roughly about 0.5 of BHB, right? So that's a nutritional ketosis level. Right. Below that, we can say you're going to be either in weight neutral, or you may be actually gaining some additional fat mass. So that's a really simple way to use it clinically to understand, okay, I'm on track or I'm off track.
Okay. Carry on.
Naomi, you, what's really interesting is that also, like, you have somebody that goes to the gym and they're working out, they're going to check their BHB. It's going to be low because you're converting that stored. So you're getting some information that really is not aligned with what's actually transpiring. Whereas your acetone levels will go up because you are burning fat. You are burning fat right at that point, and then they'll converge, over time. But it's a direct reflection of the mitochondrial use of and what's actually happening in the mitochondria with the metabolic exchange there. So I think that there's an argument, and you'll see Dom talk about this too, argument that acetone is a better direct reflection if it can be done well, and that's the key thing. And Doug, it's great that you're poking holes in that.
Yeah. Well, that's what I'm here for, right?
One of the things, just as an example of how that's used, just what I think of that is, at Dale Bredesen, which he presented his data at Metabolic Health Summit with ACEs, which is our measurement. But they've got a really simple way to do this too, and those are Alzheimer's patients, obviously, and that is to get to 7 ACEs. 7 ACEs once a day. So, and by doing that, you're creating this area under the curve, but they want that to be the peak. Every single day, someone has to hit, and it's not like entering ketosis. That's just kind of a lower to moderate ketosis. And it's simplified that way. So whatever you do, eat in a way that, and start to adjust what you eat, and it's going to be harder for some and easier for others to get to that peak every day. We have others that are much, much higher. You know, we're working with in the epilepsy space of creating a program there where it's much, much, much higher, obviously. And that's staying in that all the time and potentially having some alerts built in down the line of, hey, somebody's falling out of this area. And those alerts can be shared with the clinic too.
So as you become more adapted, does the amount of acetone produced change? I know, like, if you talk about, you know, when people first start doing this and you pee on one of those pee stick things, and then it all, as you become adapted, that all changes, right? And so do you have a similar kind of change as people become more and more adapted?
No. There's no change. So it's
the same. Okay.
The three ketone bodies. There's adaptation with urine and acetoacetate, as well as BHB over time for those that become quite adapted. And you see that with Virta's data. You know, Virta, if you look at their average ketone levels in their second, third year, you can see that go down to like a point, like 3.3 millimolar in BHB. With acetone, it stays the same because it's what you're actually using. It's what you're burning.
Okay. So you're talking about a bunch of different trials. You mentioned dalbredacin, for instance, and that. Where has this been used so far? Where are we seeing the stuff, you know, trials like this are being done?
I think there's one common thing with these types of trials is that they need area under the curve. Okay, they need to have something, and these are not, most of our clinical trials are not for diabetes, type 2 diabetes. So these aren't patients that have pricked their fingers their whole life. They're patients that they don't want to have any type of disruption to the day. So I think that all those trials have that thing in common. They're all using this multiple measurements. We just had a study here in pancreatic cancer and tumor reduction here in St. Louis at Washington University. They'll publish that at some point, really, really promising data from there. We just got a JDRF grant for the review of a study with type 1 diabetes for DKA and an SGLT inhibitor. So we have 2 or 3 studies with SGLT inhibitors because obviously euglycemic DKA could happen. We have an infertility study in Europe. We have a Parkinson's study that is grant dependent in Europe. We have, there's upcoming glioblastoma study. We have obviously obesity studies, and we have 2 pharma studies going on right now too. Okay, and one of those is in a metabolic disorder treatment injection. So I can't really comment on that though.
Okay, and Naomi, you mentioned you're from Rush University.
In Chicago, yep.
Okay, cool. I hadn't actually heard of that university before, which I don't know
If
whether
you're
I
ever in
should be.
Chicago, I'd be happy to show you around. We've got 6 different clinics, so.
I don't know whether I should be embarrassed about that or not, but anyway.
All good.
So how does it fit into the programs that maybe you've got going there?
Yeah, so our clinics are, taking care of a diverse population across 6 different sites, and we continue to expand to, meet the needs because we know there's need everywhere. And so for us, our biggest challenge is we can't hire enough people fast enough to meet the demands, right? And we also want to be able to help people who can't make it to the office for whatever reason. They might work during our work hours, and so they can't come in regularly. And so this device has been really helpful for us to think about ways that we can scale the impact and allow success across a broader range of individuals across for different reasons, right? So it's been really great to have a tool that we could give people. So for example, as you know, the CGM, really revolutionized diabetes care. Mm-hmm. And we don't have an equivalent for obesity care or weight management, right? We can say, okay, step on the scale, check how your clothes fit, right? Are your underpants looser, right? That's not really as easy to monitor and tell if you're on the right track or if the behaviors that you're choosing are moving you in the right direction. And that's where we can now use BioSense and say, hey, you can actually look at these numbers, and if you're hitting the numbers you want or trending up, you're on the right path, right? And if you fall off track, how do you know to get back on? How do you know when you're off track? So if we're using this, and let's say we have a specific number we're targeting, people are not at that number and they come in and they say, I don't know why I'm not having success. We can actually look and say, oh, well, let's figure out why this number isn't where we want it to be. We have markers now, and people can self-monitor, right, and tell what's going on much easier.
Yeah. Jim, you mentioned Alzheimer's, and I think more and more what I'm seeing being involved in this space is how exciting it is that we can see how many different neurological and mental disorders this therapy is able to be helpful with. I don't know which one of you wants to answer, but like, what are your thoughts in long term about how this might impact the mental health area?
Let Naomi run with that on the world of metabolic psychiatry and how interesting it is.
I am obsessed with this metabolic psychiatry. Absolutely. So, Dr. Chris Palmer and Dr. Shabani Sethi really introduced this concept at the Metabolic Health Summit. And it was just super fantastic to have a terminology that now we can share with other individuals, specifically in the medical world. And so I think this is the future, right? To be able to see that if we provide the right nourishment for our body and take care of our body outside of the medications, outside of interventions that are invasive, that we could have this tremendous effect. And we know the body's designed to heal and recover. And so if we set up the right environment, we can actually set up for that success, for that healing and recovery. And we know that mental health issues have been traditionally not appropriately, resolved, right? And this gives us an opportunity now to actually say, if you hit these numbers and we can monitor, you're going to know that your body is in the best place possible to respond and to get better and to feel better and resolve some of these concerns. If you are not hitting those numbers and you're not feeling better, there's a reason for that, right? So we can start connecting the dots so it makes sense, and we know when we need to step up interventions because, this isn't at a therapeutic dose. We're not there yet. We need to increase intensity of care. So I think it's going to be really, really helpful for safety and for treatment efficacy.
Yeah, you mentioned Chris Palmer. I think the last time we had an event in Boca, he spoke there, and during his talk, he kind of finished off with an anecdote of some lady who was struggling with schizophrenia or something, and how her life had changed. And it was like, when he finished, like I had to kind of kick off the Q&A part of it, and I couldn't speak. Like I had this lump in my throat that and everybody was like in tears, and just as he described what a difference it made in that patient's life. It was epic.
Doug, think about that. That is one clinician treating patients, and think about 50 clinicians or 100 clinicians with schizophrenia. How do we, and this is where there has to be collaboration to understand where over time, especially for schizophrenia, that's lifelong, they're off their medication. How do we know, based on data of a larger sample size of patients, where do people need to be? Where is the efficacy of this fantastic therapy? Where does it come? How long do they need to be in this? So what, if they come out of it, how fast is it that their symptoms come back? And by the way, they're not on medication anymore, so it's extremely dangerous. wires like that. So I think that's what we have to do, is start collaborating and looking at this dosing, quite frankly.
Yeah, but especially when you talk about the psychiatric conditions and that, it's just, and I need to put this in here, it is so critical that if somebody's going to do that, and it's especially if they are, suffering from some psychological, psychiatric condition, that it is properly monitored by somebody who knows what they're doing, like Chris or Georgia Eid or any one of those people that is operating in this metabolic psychiatric area, as you like to call it. But it's, I need to put that in there. It's really important that somebody doesn't just go off and try and do this on their own, because
exactly
it's dangerous. With people on medications, type 2 diabetes, whatever, it's dangerous if they do it without, proper monitoring. But it's wickedly dangerous for people that are on psychiatric medications and stuff. So they must be aware of that,
Yeah, I mean, Doug, it's a perfect example of, let's say somebody, they're fasting 14 hours a day, they go to sleep, or 12 hours, whatever that ends up being, and you have schizophrenia, and you wake up and you test your ketone levels and you're in ketosis. Well, that's because you didn't eat the last 14 hours. Right. You cannot make that assumption. That's where you all are, you are that day. You will go down when you have your regular food. You'll be out of ketosis, and it's extremely dangerous. I think that's Naomi's whole point on this, on safety, is we have to kind of lasso this phenomenal therapy where it's broadly researched now in so many therapeutic areas. We have to lasso this and put structure around that. And we play a part of that. Abbott plays a part of that with, they're going to come out with continuous ketone monitoring, which is going to be great for type 1 diabetes or heart failure or other diseases. And it's going to be expensive, but it's another example of, we need to provide this area under the curve of this dosing, this ketosis dosing.
Now, and I was going to ask you, you sort of started talking about that already, but where do you see this going, like in terms of biomarker measurements, and how is that going to factor into everything in the future? I see it being very important. I was wondering what your thoughts were.
From a clinical standpoint, this, it's like any medication, right? Lifestyle changes we make are therapeutic or detrimental, right? So you want to get the right efficacy by getting the right dose. So, some people think they're doing the right thing, and it turns out they've misunderstood some information, or they didn't account for their individual personal body's different reactions to the different foods, right? Just like you were describing with you and your wife. And I think this is important, is that the dose for the individual and how you get to that effective dose might be different. Mm-hmm. And then also the safety, because if we're assuming, let's say with schizophrenia or depression or anxiety, that you're using this as an adjunct, right, to help with the mental health treatments, whether they're medications, therapy, whatever else they have going on, you're using this as a piece of the treatment puzzle, and then it turns out that you're not getting the right dose, that's a problem, right? Because then you could have some complications or some exacerbations. And that's why this is so important, to be able to not only dose it, but keep people safe. Physicians want to also provide safety, right? Mm-hmm. And so this is a really great way to make sure, okay, if you see these numbers are no longer in the range that we need, come on back. We got to touch base. We got to figure out how to help you so that you can continue to improve.
So, I was just going to say, when you mentioned that, are the physicians able to actually get access to that data in real time, or do they have to rely on the patients coming back to them with their results?
So there's integrations that we have with Elation or DocSync or Heads Up Health, for example. We're about to launch a Gluco integration as well. And so you do have the data going into this, whatever system is being used by by many of the clinics, or the area under the curve. Let's say you're seeing in obesity, you may be going in every week. So you can go in and just show your numbers, or you can text, send an image of your area under the curve to the clinic, which is not as ideal. in the epilepsy world, for example, some of the things that we're working on is that the parent can actually monitor their child and their ketosis levels while they're at school. Okay, and those are some of the things. And again, we're developing these programs like that right now, so it's not in use. But those are some of the things that can be done. I wanted to add too, because you were talking about this, getting back to that personalized thing. I want to give you another example. We've got a study coming up in what I think is the absolute lowest hanging fruit out there for ketosis therapies, and that's in orthopedics, right? So I had 6 knee surgeries. That's how I got sucked into this world of ketosis for the rest of my life. And these are people that are trying to get to some type of anti-inflammatory level of ketosis. And it's different for everybody. And I can tell you, if you're telling somebody before surgery, hey, go do a 24-hour fast before surgery to reduce inflammation, that's just not going to work, because 24 might be good for you and it's not going to be for Naomi, right? So the key thing is, hey, we want to get you above 10 ACEs, for example, which would be like 1 millimolar for a 24-hour period. So the time in that range in preparation of a surgery, as an example, very rudimentary example, that's when you start to see the impact to something like that. And that's a simple one, really simple one.
Okay, so Jim, don't you want to tell us a little bit more about the device itself, the company itself, and how people especially can come and learn more about it and get their hands on one?
Sure. So the company's in St. Louis, next to Washington University, which is one of our study partners. And it's been around for about 2 years, the device itself. So Readout Health is the company, BioSense is the device itself, and then the digital program comes with it at no charge. So the device is $299 at mybiosense.com. Also available at Best Buy, Best Buy online, and that's it. That's how you get it. Right now, the digital solutions within there of giving your area under the care of all of that's free. So there's no charge to that. We're building a lot of that out with a lot more curriculum and content to help somebody get through this metabolic journey, whether it's fasting or ketogenic diet for first time patients.
But you talked a lot about the research that's gone into the device. Not only that, but also then how it's being used in research in terms of the ketogenic therapies and stuff. How can people learn more about that and the different trials that you were talking about that you're involved in? Is there a way that they can get access to that kind of information?
mybiosense.com.
So if they go to mybiosense.com, they can see what you guys are working on. Okay. Yeah. Awesome. Yeah, no, this is exciting. We live in exciting times. I think there's so much that we didn't know up until a couple of years ago. That suddenly there's all these areas of research, and we're seeing how many people, lives we can save, lives that we can make so much better and more enjoyable. And it's cool to be a part of that environment. I get that you guys feel the same way. So thank you so much for being on this talk with us and for doing what you're doing. I think it's not only fascinating, but it's helping so many people. And okay.
Doug, thank you so much. What you're doing is actually amplifying everybody who's in this space, right? To allow us to make that change. So thank you for LowCarbUSA and creating this venue.
No, I appreciate that. Thank you.
Yeah.
You've been listening to an episode of the LowCarbUSA podcast. You can support us on Patreon at patreon.com/LowCarbUSA.